By way of disclosures, I didn't make up the healthcare system in the U.S., so you can't blame me for it. I'm just reporting on this. I have helped, though, as I think most of us have, to add to the financial toxicity of many people. Financial toxicity is a topic that it's the elephant in the room. We don't want to think about the cost that we have imposed upon our patients. We get excited about new therapies. We get excited about intensification. But all the time, all this means more cost to the patient. So I'm not really here to criticize the system, and we've got several international colleagues here who can just sit back and smile because maybe things are better in their part of the world. But I just do want to bring this to everybody's attention because I think it's imperative that we wake up and start to look at the cost that we're imposing on our patients. So if you look at healthcare costs in the United States, they're increasing. I think this is no news flash to anybody. Our costs are about double the rest of the world. What is interesting, though, is the amount of that cost that's being shifted to patients. If you look at this particular slide, this really doesn't go back as far as it should because the patient cost shift started in around 2010 with the inappropriately named Affordable Care Act, which shifted all the expense to the patients. And you see, it's growing at 10% a year, what the patients are having to pay for out of pocket. So really what this talk is sort of an extension of Dr. Hahn's last message talking about the caring for the whole patient, because this is the rest of the story. If you look at the Organization of Economically Developed Countries, you'll see that there's only one country in this group that has a higher out-of-pocket patient expense, and that's the Czech Republic. So go USA, right? Spending on cancer care is a major driver of cost, right? So not just the out-of-pocket medical expenses, but this cancer care expenses specifically. If you look at the cancers we treat, we account for almost a quarter of the cancer spend just in our small practice. And it's been increasing, it's more than trebled in the past 2 decades. $200 billion will be spent this year on out-of-pocket cancer care costs. $200 billion out-of-pocket from the American public. So why is cancer care so economically burdensome, or moreover, how does it hit the patient? This is a really interesting slide to me because if you look at these different levels, the left-hand side is people without cancer, the right-hand side, people with cancer. I mean, 46% say they've used up their savings without cancer in their life. 60% say they're out of savings with cancer. They've withdrawn from college or taken their kids out of college or taken their retirement funds. They skipped or delayed medical care due to cost. 3/4 of people who have cancer have had to skip or delay medical care due to cost. And then if you look down at the bottom, you see that almost 1 out of 4 people with cancer have declared bankruptcy or lost a home. This is real, folks. This is real. And this is, believe it or not, part of medicine. You know, when I went into medicine, I think most of you can relate to this, I didn't want to talk about money with patients. I felt like that was yucky. Right? That was not part of medicine. I didn't want to talk about how much it was going to cost because I didn't want to seem like that money-hungry doctor, but I also didn't want to think, in my mind, about the cost I was imposing on the patients. Well, I believe that now that things have gotten the way they are, it's imperative, it's part of the decision-making discussion that we have to have with patients to have truly informed consent. Whether you're talking about a stone and the different ways of addressing a kidney stone or cancer, it's a part of every conversation, or at least our thought process we have to have when talking to patients. So the economic burden of cancer care is disproportionate, okay? I've shown you how big it is on the American public, but what's even worse is like so many other things, it affects underprivileged populations disproportionately. So you can't probably read on the right side, but it impacts people with no college education. It impacts women more than men. It impacts both Black and Hispanic populations substantially more than white populations. And this is a call to action. It's time for us to do something about this. And also, it's a time for us to do something about it, because if we don't, somebody else is. Those of you who have been around for our legislative health policy talks know we like to use a phrase, if you're not on the menu, you're going to be on the table. If you're not at the table, you're going to be on the menu. Yeah, the skiing was hard today, but good. We don't want the powers that be in D.C. to correct this for us. We want to do something proactively ourselves. So it's time for us to look at how we can help this financial toxicity. Physicians drive these costs. There's a busy couple of slides shoved into one slide here, but what I would point out to you is that the physician drives about 70% of the healthcare dollars spent. Now, that's not in our salary or anything like that, but it's in the costs that we make. So if we're using a costly site of service, we need to think about directing it elsewhere. In the right-hand graph, you can see a couple of things pop out. One of those is in the gray zone, and that's the cost of drugs. I mean, this has gone up by about 700% over the past couple of years. Fortunately, we have a little bit of good news in this presentation, and that's that Congress has done something about it, and I'm not going to call this bad or good, but it is something. And the changes to the Medicare Part D that go into effect this year are going to bring some relief to this situation. Historically, what we've done since Medicare Part D went into effect somewhere around 2004, I don't remember the exact date, is this complex stack of who pays for what throughout the year for each patient. It's capped at $3,100 for the patient, but it wasn't really capped because there's an ongoing 5% even beyond the cap. So now, starting this year, there's 0% beyond the cap. It's a $3,300 cap for the patient in Medicare Part D. But going into next year, again, there'll be no expenditure out of pocket over the cap with a $2,000 cap. So put another way, there's zero out of pocket for the patient. Every Medicare Part D patient will have $2,000 they're responsible for, but at least we're going to make a dent in the impact we've been having over the next year. So, I've been excited to hear that this topic has come up somewhat tangentially throughout the day. Dr. Collins talked about oligometastatic therapy and the number one decision driver by patients and their decision making on his slide was the cost. Dr. Hahn mentioned the cost of things like abiraterone. It's time for us to start looking at things like, orchidectomies. Maybe we look at revisiting some of our trials, and do we have to have ADT along with that abiraterone? Or does the abiraterone or the ARI do the job all by itself? Look at the ENZA-only group in the latest EMBARK study, right? So do we have to impose all these toxicities, financial toxicities, on patients? So the costs are rising. Financial toxicity is a true effect, and there's one of two things are going to happen. DC is going to continue to step in and tell us how to practice medicine, or we can come up with a solution. I think financial toxicity fits perfectly into Dr. Crawford and Tolmar's effort on the Prostate 360. It's more than just cardiovascular toxicity, it's financial toxicity too. Thank you.